Good evening, everybody. Good evening, dear colleagues, especially from Russia and from Poland, but also from all Europe and from the whole world. I have a pleasure to share this session. My name is Thierry Ponchon. I'm from France. I was the past president of ESGE. And I want to thank first ESGE for having organized this webinar, and of course IPSEN for having supported this webinar since the beginning. And we selected this topic, applying lessons of the pandemic to colonoscopy. What does that mean? It means that we all suffer from the pandemic, especially when we perform or when we organize colonoscopy. So maybe, or unfortunately, it can recur, or we can have another pandemic from another disease, another virus, why not? An economical crisis, a political crisis. So we need to draw conclusions from this pandemic, and we need to apply lessons in case we have a new crisis. So that's why I'm happy to share this session, and I'm happy that we have two excellent lecturers. Evelien Dekker, she will speak about alternatives to colonoscopy in case we cannot perform any colonoscopy, or can we replace colonoscopy by another examinations. Cesare Hassan will speak about quality, for example, to reduce time, to spare time and to spare resources. And I will be in charge to speak out different possibilities, for example, optimizing resources, etc. We need to think about in case of new crisis. So the first speaker is Evelien, and you should interfere. I say to the audience, you should interfere. You can ask any questions. We will be happy to answer the questions. Don't forget that, especially in Russia, you should become member of ESGE, but in all Europe too. And I will also announce now Evelien. Evelien, please, can you speak about alternatives to colonoscopy? Are they realistic? Evelien is a very famous endoscopist, and she's from Amsterdam Medical Center, and she's a great colonoscopist.
Thank you so much, Thierry. This is a great honor for me to speak tonight from Amsterdam, from my home office. And I'm indeed happy to discuss with you potential alternatives to colonoscopy. So first of all, I would like to share with you potential conflicts of interest that you will see on this slide. So as you and all the audience will know, is that colonoscopy is the best method to detect cancer and also many other diseases in the colon. However, it also has a burden, like the burden for the patients to undergo a colonoscopy, the risks, the workload for doctors, and of course also the high costs of colonoscopies. However, we, as you know, have recently met an unprecedented health crisis, the COVID. And of course, that crisis also had a clear impact on endoscopies being performed in all our units. So the English were one of the first ones to report on that in literature. And you can see, I think, quite clearly in this slide, the upper line, which is the total number of all types of procedures performed in the UK, which was up to normal until the crisis started, and then really went very quickly down to a very low state. And only slowly after that recurred a little bit. Most of those procedures that were not performed anymore were OGDs, plexi-cigs, and also most colonoscopies. As you can see here, the line is at almost zero. And only ERCPs, of course, as mostly a more kind of an emergency procedure was still performed. Also in my country, in the Netherlands, it was reported on the number of endoscopies, and you can see that clearly here. So also in our country, ERCPs kept up quite well, but as from the COVID crisis start here, screening colonoscopies as well as normal colonoscopies for any other indications went down, but by time increased a little bit further. And you can see the same for gastroscopies. So really a big halt or at least big reduction in performed endoscopies also in my country. And of course, that has an impact also on colorectal cancer screening. Again, the UK here showing that indeed almost all procedures performed for screening were almost halted to almost zero early after the start of the pandemic, and then only increased a little bit further. And what they announced is that they were expecting a 72% reduction of the number of cancers that should be detected during that time period, not being detected. So a big problem was foreseen. Also, a huge projected backlog of endoscopies of in total 500,000 for the UK. Here you can see the same type of problem in my country. This is from another publication showing that also the cancer diagnosis per week also in my country went down. You should have a look at the blue line, which is all types of cancers, including colorectal, just not the skin cancer, because patients were just not going to the doctors, as you can see in the green line here. So also in my country, less cancers diagnosed at from the start of the pandemic. So large backlogs, potential huge consequences for cancer diagnosis and early detection. So how should we deal with this? Can we select patients maybe that need colonoscopy for a good diagnosis and optimal treatment? So can we choose which ones would need that? What are relevant diagnoses then during the crisis? Is it cancer, advanced neoplasia? Is that relevant? IBD, maybe any other diagnosis you would think is relevant even during COVID crisis? And then also, how can we optimize the timing for colonoscopy? Does it have to be performed urgently, or can we postpone a bit? And then last but not least, as Thierry already alluded on, can we then learn for the future for further potential other crises? There's several methods to triage for colonoscopy. So to choose who should undergo a colonoscopy and who should not, or at least not be prioritized. That can be done based on clinical indication, like we usually do in our daily practice in the outpatient clinic, by non-invasive tests and by less invasive tests than colonoscopy. And I will come back to that later. First of all, again, this is what has mostly been done also during the COVID crisis. This means triaging based on what we know from the patients about their complaints and their health status. So we could say then, well, I think there's a high suspicion of cancer. We should do an emergency colonoscopy. Otherwise, he might even die soon. An urgent endoscopy. Maybe screening or just elective. So we can do it that way. The US National Delphi Consensus Panel published 3 timing categories to guide clinicians in their country. And you can see them here: emergence within a week, urgent, or non-time sensitive, to guide and again to help clinicians a little bit, because this is of course not so easy to place every patient just in one of those boxes. Another way of triaging patients could be using FIT. FIT is the fecal immunochemical test that we use for colorectal cancer screening to select patients at higher risk for advanced neoplasia, so cancer as well as advanced adenomas. The advantage of this test is that it's non-invasive, cheap, easy, and quick. We have many data on using FIT for screening, including on the different cutoffs. And we know usually it has a 4 to 7% positivity rate, depending on the cutoff in the general population. So again, we know it's how it works for screening, but not so well for other indications like we discussed, IBD or any other diagnosis that we would want to make in COVID time. This is just one slide on that cutoff issue. As I said, the cutoff really decides the sensitivity and the specificity of the test, which means that if you use a low cutoff, it would mean that your sensitivity will be higher, like in this case, for this cutoff, 88%. So you find almost all cancers in a certain population. However, your specificity will be relatively low, which means that you have to do more colonoscopies to detect those cancers, but also do more negative colonoscopies. So if you want to triage, probably you should increase your cutoff level, maybe even higher than the cutoff levels here for screening. But again, we don't have much data for any other diagnosis. Could we use other fecal tests as triaging? Well, we have the Cologuard, that is the test with molecular markers as well as a FIT included. It's relatively costly. We need a large stool sample that makes it less easy because you can send it by mail, but it's a relatively large box. However, the accuracy for colorectal cancer is a bit higher than for FIT alone, and especially it does better for large adenomas and SSLs. However, the specificity is lower than the FIT. And again, data in screening, but not for other indications. So I think not so well applicable specifically in colorectal cancer screening in COVID. Fecal calprotectin for IBD, of course, is a well-known test that could be done to see whether a patient has an inflammation that could be IBD, or maybe could be a recurrent IBD. So that could help maybe a little bit. You know that from the literature that that's possible as well. So there could be other potential ways to look in the stool for a specific diagnosis. How about the other tests that sometimes are called non-invasive? However, I would like to argue that a little bit, because I think CT colonography is indeed less invasive than colonoscopy, because we don't have to introduce the whole colonoscope. On the other hand, patients do have to prep, depending on the schedule in your center, a lot or a little bit less, but they usually have lots of diarrhea. And besides, they need insufflation by a catheter with CO2. So usually patients expect a CT scan, which seems not to have a big burden, and then they are kind of disappointed by this examination. But of course, it's less invasive than colonoscopy. We know from literature that the accuracy for advanced neoplasia is approximately similar to that of colonoscopy, so it does quite well. However, we know that flat polyps and as well as SSLs are not well detected. Besides, of course, I don't have to tell you that once you do see a lesion, usually a colonoscopy has to follow anyways, because we need to have a proper diagnosis. And in case of potential resection, this should also be performed during a next colonoscopy. There was a report from London that during COVID saying we have capacity available for CT scanning. Why don't we see more patients? However, I think that's not the usual situation in most countries and most cities, because there's, of course, like with colonoscopy, the issue of logistics, of costs, of potential risks for infection when visiting the hospital, and also capacity issues. And also here we have data on colorectal cancer, on polyps, some on IBD, but not so many on other diagnoses that could be made. How about the colon capsule as a triaging method? So also, again, it's less invasive, but not non-invasive, because I think, especially because of the extensive prep that should both promote protrusion of the pill through the GI tract, as well as make sure that the colon is absolutely totally clean, because it's impossible to flush or to suck away potential leftovers of the materials in the colon. We know it has a high sensitivity for cancer and advanced lesions, so definitely potential there, but still also issues to be solved, like the prep, the logistics, the costs, capacity, and potential complications, although of course rare. But for example, in symptomatic patients for IBD, this of course is a risk. And yet, as of today, there's not so much clinical data yet, but I know some clinical data of large studies are on its way. So these are the methods again, and we could maybe also combine some of them, like clinical indication with fit. And this is being done quite extensively in different trials in the UK. Like in Scotland, what they did is they looked at the patients and the indication, and then they triaged to either fit plus CT, others only fit, and if the symptoms or the suspicion was high enough, they sent the patient directly to colonoscopy. And they compared this with a historic cohort. And what they saw is they did equally well in detecting colorectal cancers, but by triaging through fit plus CT, but also by fit only, they reduced the number of primary care referrals by 43%. So they thought this was a good way of triaging their patients and not sending them all to colonoscopy. Also, a report in literature on Lynch. I think that could be debated. As you know, patients with Lynch have a high risk for colorectal cancer with an annual risk of 1 to 40%, depending on the type of the germline mutation. And biannual colonoscopy is usually advised. And what the English colleagues advised that they said we have a huge problem in the UK, which I think, reading from most literature, it was really, again, a huge backlogs, especially in the UK. So they said, we have to think of a solution, how to cope now with the waiting lists. And they said, well, we could prioritize those with Lynch by performing a fit and saying, well, we as soon as the fit it has a certain cutoff level, we should perform an immediate colonoscopy, and otherwise we have some time to recover from that. In my opinion, this could be debated, because I think Lynch should not be in the surveillance or screening region for risk. But I think because of the high risk of those patients, we try really to keep the time, even in times of crisis, for these patients. So this is an interesting way to look at it. I guess in the UK, they don't mean we can postpone for a long time, but triaging in some way could help a little bit here. In Ontario, they did also an interesting exercise. They did some modeling on looking how to recover with the big backlogs, and they compared the strategies for that. And they looked at the low-yield colonoscopies, which they included surveillance for low-risk adenomas and those coming for screening. And what they said is, well, when we use FIT, we need less time and less colonoscopies to recover. And here you can see the calculations, and I will guide you a little bit through it. This is the graph for patients that first undergo a FIT. And what they said is, well, if we look for a conversion and we send a lot of patients FIT instead of directly to colonoscopy, we only need 115% capacity for colonoscopy, so just a little bit more to recover in 18 months. Whereas if we don't convert, so if everybody will wait for the colonoscopy, we have to, with the same capacity, we need much longer. Instead of 18 months, we need 14 months. So only if we would really increase the capacity, we would be ready in the same time with recovering from the backlogs. So they also advised to perform FIT for triaging. FIT for screening, I think it could be debated how quickly colonoscopy should be performed after positive FIT. We know from data that it should be at latest within 9 months. However, I think for patients, the burden of having to wait for a colonoscopy after positive FIT is really high. They're usually very anxious and worried, and we shouldn't wait too long. We should consider changing for screening logistics of methods for the screening programs. So, for example, programs that do colonoscopy should think of moving to FIT to make a more efficient strategy. Consider further prioritization, for example, by using age, gender, screening history, or changing the FIT, or considering moving all cohorts just to a little bit later stage. I'm nearly finished, Thierry. So we've seen from literature that indeed in the US something that has happened as well. In the past, they were really always believers in colonoscopy. And we can see after the COVID crisis that now more non-invasive testing for screening is being performed than invasive, which in the past was the other way around. So I think this is the way to prioritize, combining fit with clinical factors. I think we should learn from this health crisis and make our systems more efficient to prepare for a next pandemic. And I look forward to see you all also at the ESGE days. On Thursday, we have a day also with lots of different issues and talks on colorectal cancer screening on the Thursday, April 28th. Thank you so much.
So a great thank you, Evelien. Very clear, of course, as usual. Just one question from the audience. How do you select the first alternative? On which patient factor? I suppose FIT is your favorite or number one, but nevertheless explain.
Yeah, so what I find, I think for screening, it's very clear to me. I think screening by colonoscopy is just not the way to go. So for screening, my answer is very clear. However, for other indications, I think we don't have much data, whether we do so well with FIT. So probably still clinical factors and indicators are probably number one. And if then really we need something else because we have less and less capacity, FIT could be a potential second one because it's easy and cheap. But again, I hope more data from the UK will help us and guide us here.
Okay, quite clear. A great thank you, Evelien. Okay, maybe we will come back during the discussion on your talk. Now, it's my pleasure to announce Cesare Hassan, who is still the treasurer of ESGE and who is now working in Milano and no more in Roma, okay? So he's in charge to speak about improving quality. It does mean that we will try to spare time, we will try to spare resources if we improve the quality. So can you explain us, Cesare, how it could impact on timing, etc., if we have a new crisis? Thank you very much, Cesare.
Thanks, Thierry. I guess that your message is very well taken. So Evelien already anticipated what happened. Of course, a tragedy. All the FIT program in Europe disrupted. 50% of population uncovered. You want to have diagnostic colonoscopy, 70% to 100% of colonoscopy completely canceled. And then we had the delay, not only in endoscopy resection, but also in surgery for colorectal cancer, because ICU were full with the COVID patient. Basically, what happened was a double tragedy. We converted an infective pandemic in an oncological colorectal cancer epidemic. And Evelien already anticipated better than me that we can expect at least a 20% increase in death due to colorectal cancer. I guess that the message by Thierry is that if this is a tragedy, to be not only more than a tragedy, but it be very stupid not to expect a second outbreak. It may be a new wave, it may be a different type of crisis. And having said that, my best wishes to all my friends in Russia. I learned from Sergei Kashin that the situation is still very difficult and all of you are in front line. So what did we learn, Thierry, from this? I guess we learned that the endoscopy capacity is not adaptable. It is too rigid. We are even unable to assure what is the most life-saving procedure we do. And I guess, Thierry, that your message was that there is still too much variability in your endoscopy community. And what is specific of this pandemic, Thierry, is that we learn that we need to convince the patients who have a fear to come to our endoscopy endoscopy, to return to our endoscopy in order to prevent cancer. So there is a new actor in this crisis, and this is the patient, the other side of the coin. So when we think about colonoscopy, we don't need to think only to get to the cecum. We need to think of the benefit that we can deliver. And this benefit depends only on two factors. And this is the expected risk of cancer of a specific patient and the quality we may provide at the time we do endoscopy. And this means to refocus on all the stakeholders involved. We need the right patient, we need the right setting, we need the right endoscopy, we need the right quality, and what is technology giving to us and to our patient. So this is the statement, Thierry, that the ESGE board did when you were leading it, and the first message is that we need to prioritize indication. This theory was extremely new for ESGE. We never put it so black and white. It was not a problem, but now it is a problem, because if you need to cut 70%, you need to tell people where you put the remaining 30%. Evelien said, let's do FIT. Of course, Evelien, we do FIT. But in order to do FIT, Evelien, you need to have colonoscopy for FIT positive. Because if you don't give this lot to the FIT program, the program are blocked, are disrupted. And this is what happened. This should never happen again. So the first duty of endoscopy is not to stop what is non-endoscopy, that is FIT. Endoscopy should never block a population program, never, ever again. And this was what happened instead. And similarly, I heard when I was a kid somewhat that the UK, they have this 2 or 4 week rule for those with alarm symptom. I remember that in Italy, we tried a lot of time to do it, but we don't have it. I don't know what in France, Spain, in Russia, but this is a very basic rule of endoscopy. And too many patients with the low-risk adenoma tend to return to endoscopy, and too few patients with the high-risk adenoma come to us because they still have fear of COVID. All of this must change. So the idea, Thierry, is that we are too much isolated actor. I am in my center, I do everything. If I cannot do, okay, that's all. What we need to do is to change our organization. We need to become a network of centers. In this case, we can enlarge the capacity we offer. And if some center is unable to provide dedicated slot for FIT because of a hot crisis, it may be infective, it may be economic, it may be blah, 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 then we need to move this capacity to the cold center. And so we become a company of actors who are on the same stage for the same show, that is to prevent cancer. So we need to stop to be isolated. We need to network. The same for resection. What happened, and this we need to pay tribute to Mario Diniz Ribeiro, was a substantial reduction in EMR and ESD for persons who had advanced neoplasia very close to become cancer. So even here, we must understand that we must link each other in a better way, and that complex lesions deserve complex center. A complex center does not mean a center where there is one very proficient guy in EMR or ESD, or a center where there is a very good surgeon or very good oncologist or very good radiotherapist. A complex lesion must be dealt with in a center where you have all of it. You have proficient endoscopy, proficient oncologist, proficient surgeon, proficient radiotherapy. And thus, we need to introduce the second organizational change. And this is the hub and spoke approach. That means that even during a crisis, all the centers can refer patients to a tertiary center able in management of complex lesions, respectively of the region. It may be even out of my region, for instance, in Tuscany or in Lombardia, the patient travel, have the EMR ESD, and then come back to my region. So this organizational change is the lesson of this pandemic. But now let's focus on quality, because quality is a determinant of the benefit of colonoscopy. And we know from Mike Kaminsky that still too many cancers happen because they were missed in the index colonoscopy. Of course, it was during the magic period and pre-COVID period of ESGE that all of the key quality indicators were provided. Matt Ruther, Ralph Bishop, they did an excellent job in telling us what we should measure. But this was never fully implemented in our community because there was too much reliance by all the stakeholders on us as endoscopists. But we cannot do everything. I cannot be responsible of measuring my own quality. I cannot do, at the end of the day, the match between my colonoscopy and the pathology to measure my own adenomatization rate, decide how to improve, whether I need to improve, etc. So what we need to do is to claim a top-down approach for measuring quality. And this top-down approach should be coming from a screening program in most of the European countries that have screening program. And I also know that, of course, in Poland, but also in Russia, screening programs are coming. And we need to deal with big data and to plan interventions. So let's use what we already have. And this is the big data that is in the electronic medical record of our screening program. Why are these data so important? First, because they are automatized. Every time we do a FIT colonoscopy, we put the data in a software. Secondly, this software centralizes all the data that we have in our region and then can disaggregate and give the feedback back to the endoscopy. Third, the big data can integrate endoscopy with pathology, pathology with surveillance. As Evelyn anticipated, it may be the FIT value with the need of endoscopy, etc. Then these big data are multidimensional. I can measure the interval cancer that occur. I can measure the perforation after a polypectomy. And then Mike showed that we can measure the feedback of the patient. And we can benchmark all the center within the center, all the endoscopy. But of course, we need high quality data. This is, for instance, the first example coming from the FIT program in Italy, where we had all the ADR of the different centers, and we could benchmark them against the average. All of this was completely automatic. And this is the same experience in England. And I know that also Evelyn did the same in the Dutch screening program. This is again from a primary screening colonoscopy, so you don't need FIT. This comes from Mike Kaminsky, and this is the ADR of the endoscopist doing primary screening colonoscopy. But I really like this. This is the first demonstration by Matt Ruther that you can assess the risk of adverse event of colonoscopy in a screening program center by center, endoscopy by endoscopy. This is big data. This is the automatized way to measure quality. We need to have it. But if we are in the outbreak, as we were now, you cannot measure quality because all the population is completely different. So you need to have a core. You need to assure the patient a minimum of quality. And this means a good quality preparation and an adequate withdrawal time. For bowel preparation, I was responsible to renew the guideline of ESGE. And when we renew this guideline, we realize that what we cannot afford, especially in an outbreak, is to waste colonoscopy resources for duplication. That is to repeat the endoscopy in a patient with a bad bowel prep. This is unaffordable. But we also learned that we are very good in telling the patient how to do the first preparation. But if the first fails, we are not so good. So we cannot afford to fail the first attempt of preparation. And in order to do this, we need only to follow the rules. Because when we look at randomized trial in colonoscopy published, for instance, from Evelien or from Thierry group, we realize that over 95% of patients had adequate bowel prep. So we can do it. We need just to follow the rules. And this is why we gave very simple recommendation. This is to split the bowel prep and to use a laxative that was tested in randomized trial. This is the meta-analysis, Thierry, that we did to support our meta-analysis, but we show that all the PEG and non-PEG that were validated in randomized trial are effective as the high volume. And this is the inclusion of trisulfate for the first time. And I'm very happy with this drug because I was with Doug Rex in Indiana, and he is using extensively this drug. What can we do in quality is also to exploit software. Software improve our quality of life. Just think of Google Maps. Just think of your app for the bank. Just think of an app to shop, Amazon. We can improve the quality of life. We can improve the quality of colonoscopy. We need to use software to improve the quality of colonoscopy. For instance, even very good endoscopists, even Japanese endoscopists, miss 14 out of 100 lesions that are on the screen, and we fail to detect. And this is why we need deep learning, as we have on our phone. So deep learning allow this mistake not to happen. There was a polyp there, there's a polyp here, and with deep learning, you can have a look very easily. And this is the randomized trial we did in the West, showing that the ADR of expert endoscopy increases with AI. But we also need AI to be confident that the examination is complete. How often we get to this ileocecal web, but it's not so easy to get to the appendix. But we need to get to the appendix. And this is a software that will certify whether we go to the appendix and whether we withdrew with an adequate speed of withdrawal. And if we accelerate in withdrawal, it will beep and it will slow down, and it will tell the patient whether we were good or not. But are we confident that we explore all the mucosa? This is where this software, very similar to architectural software, can help us in understanding whether we look at all the mucosa, where a polyp is, how to approach, how to put our snare, our knife, etc. So the final lesson, Thierry, is that we need to react by rethinking all of the organization of our center. We must provide higher and more flexible capacity, both for diagnosis with network and for complex resection with hub and spoke. Quality assurance must be automatized. Epidemiologists must understand that this is a priority and we cannot do it alone. But digital health will also penetrate our field, and we need to be ready also to interact with patients by telemedicine. You want to know more and all of this, you must come, sorry, Thierry, you must come to ESGE days in Prague in April. You must submit your abstract of what happened during the pandemic in Prague, and we'll be there just with you. Thanks, Thierry.
Great, thank you, Cesare. I will give my talk, and I suppose that when you are speaking about quality during crisis, you mean also quality outside crisis, permanent quality, of course. Right? Then it will be helpful in case of new pandemic. So I will move to my talk. So the topic is optimizing and sparing resources, and these are my these are my disclosures. And then this is the plan. So I will be brief concerning the different parts of my talk. First of all, permanent rules. It is more or less that you spoke about Cesare, but we need to write these rules, okay, on how to postpone and reschedule. We need to define the priority levels, information for patients about the reason for postponing, documentation of a decision in their files, and letter to referring doctors. Of course, we did this, but it has to be written definitively, and it has to be spread in our institution. Protection against droplets. Droplets means particles more than 5 micrometers inside. This is very important. So we have two possibilities. The first one is PPE, personal protective equipment. Of course, we know all this. We use them a lot. Not at the beginning, unfortunately, but then, fortunately, we did not suffer from shortage too long. So we need to have written rules concerning when and how to use PPE. Written rules concerning availability of PPEs on stock level, maybe 8 weeks, okay, but at least it has to be established with the administration of the hospital. And the question is, should I favor a local production, regional, national, European? Of course, I need to discuss at a national level or at a regional level. For example, all the gloves, they came from Malaysia. So personally, I think this is not a tragedy, but at least it is a pity. We should change the way we organize the production of such devices, even if maybe even if we increase the price. So just an excellent example of what we can write are these posters from ESGE concerning donning and doffing PPE. So I want just to advise you to have a careful look and to use these posters. The question is probably more interesting. Should I agree on face masks, face shields, and anti-droplet boxes? So these are different protection which has been published, at least in the journal EIO, face mask and face shields. Different, a lot of innovations, a lot of ideas, also concerning boxes, anti-droplet boxes. So the real question is that, should we have a stock of these devices? I'm not so sure. But nevertheless, what I'm sure is that we should protect from droplets. Because if you look at this study, which evaluate fluorescent dye-simulated patient cough, you see a lot of projections from the patient or in the room and droplets. So why not to have a stock of this device in case? So this is a question we need to solve together. Now, protections against aerosols. Particles less than 5 micrometers in size, including desiccated droplets. So in fact, the difference with droplets, they can stay aboard for 16 hours and they can travel long distance. They can transmit the COVID. Does explain superior spreading events, or it has been demonstrated in experiment studies on animals. At hospital, for example, COVID can be found because of aerosols on toilets used by COVID-19 patients. When you flush the toilet, 40 to 60% of particles rise above the toilet seat, for example. And especially in the room where you remove the PPE. This is a very dangerous room, in fact, if you paradoxically. So my question is, should I build my future endoscopy? In case you have build a future endoscopy with, in the unit, 2 rooms for triage, pre and post, or a dedicated room, a dedicated circuit for positive or at-risk patient? And in general, should I think more about a specific ventilation air conditioning system? In fact, dedicated room, which parameters I should analyze? These are basic parameters: humidity, temperature, proper air direction in the room, maintenance of the filters. But there are 2 main parameters. First of all, the volume of air exchange, which should be sufficiently high, and ISO 5, more than 50 volume room per hour. This should be the rule. But more important is to think about the pressure in the room, because the pressure in the room should be less than in the adjacent areas to prevent airborne pathogen from leaving the room. Then you protect the staff around the room. But in fact, in the unit, we usually have a positive pressure because you want to protect the patient open wound. So you protect the patient, but you don't protect the staff. So there is a dilemma. And in fact, positive pressure pushes air from the operating room into the adjacent recovery area of the corridor. And you can contaminate, in fact, these areas. So you should analyze how is the extraction of air in the adjacent rooms. At the best, you create a special room, anteroom, called airborne infection isolation room, at least with 12 air exchange per room per hour. And this room can be used for other activities, sedation, intubation. So think about in case you rebuild a new unit. Now, also you need to think about specific ventilation air conditioning system. Why? Because of these aerosols, and you need to know how it works. You need to know how it works. And in case you don't know, you need to refer to a technician and you need to understand. The problem, there are plenty of systems, centralized, decentralized, with or without air recycling. The best options, decentralized system, to avoid to be contaminated by other colleagues or other units without air recycling, and it has to be recommended. Now, devices, we suffer from shortage for some device. So the question is, should I increase the stock? Should I matter where the device is produced? For example, probably better if the device is produced in Ireland than in China. Should I favor reusable if permitted? Difficult because it does concern only few devices. Should I reuse single-use device? Of course, in France it is impossible. Nevertheless, the new regulations are not so strong and not so strict. They are vague concerning the reprocessing of single-use device. And you can do it if the national law permits it. So, and finally, the sentence is the reprocessor of single-use device should be considered to be the manufacturer of reprocessed device. And that means that it is possible, but then you are responsible. So it's probably not an easy debate or not an easy decision. Now, endoscope, single-use versus reusable. There is a new pandemic or political crisis or etc., etc. Now we know that we can have single-use endoscope. They are on the market or they are soon on the market. But maybe in a soon future, we will have single-use gastroscope and single-use colonoscope. So really there will be a balance, and it has to be discussed in between availability of single-use endoscope, if they are produced very far from your country. On the opposite, sustainability of a maintenance, because you need to maintain a reusable endoscope, availability of detergent disinfectants, they should be produced locally, for example, and no reallocation of human resources. The people who are in charge to reprocess, if the people are in charge to reprocess endoscope are relocated to, for example, intensive care unit, then it's a tragedy for you. It's a tragedy for your unit. So medications, very shortly, should I increase the stock? Should I matter where the medication is used? 70% of active compounds come from India and China. So it has to be discussed through a national or European policy. Of course, you cannot decide alone, but at least maybe we can, at least ESGE should promote maybe local, regional, European production. Optimizing human resources. First of all, same-day discharge. Of course, then you spare resource. You can maybe treat more patients, and it does work even for recent invasive procedures such as ESD and myotomy. You see, it has been published recently in Endoscopy International Open. So why not? Increasing the time slots. So this is very debated. You can discuss a lot about. Should we need to work on a weekend or evening? At least, in fact, in this study, working on Saturday evening, etc., they met the standards from UK regarding the number detection rate and second intubation rate. So that means that when you work on the weekend, you are still quite effective and quite good. Even you, Cesare. And now, Flexible work. I think this is a very important topic, but maybe for the future. Remote working is not very, does not really apply to endoscopy, of course. No? But flexible arrangements can apply to endoscopy. It has to be preferred to rigid work hours. As a maximum, the concept of next-gen work. But what does it mean? Part-time, temporary, contingent, independent, freelance contracts. It allows people to supplement incomes over short periods. It's not only for healthcare, but it should also apply for healthcare, and why not for endoscopy? And finally, telemedicine. Of course, these are two excellent reviews concerning gastroenterology, but does mainly concern IBD and liver disease. Can this telemedicine apply to endoscopy? Or it could be more difficult. It concerns consultation, follow-up, a capsule, but why not ERCP and EOS and see these two last papers about telemedicine to analyze ERCP at a distance and to help our colleagues to perform ERCP or to perform EOS. But it's not a novel topic. See these papers from 6 years or 15, 18 years. But in fact, it did not evolve a lot. We should think more about medicine. And others, how to sustain training, how to produce a guideline, how to sustain research in emergency when you have a crisis, just sustain training. Look at this paper recently published. In fact, fellows perform in US more or less 50% procedure, 50% procedure. So it's a huge dramatic. It's a real dramatic decrease of the possibility to be trained, and more important for lower endoscopy compared to upper endoscopy. So it does concern more colonoscopy. Nevertheless, we can have EOS e-training course, and it could help to maintain training even during a crisis. So these are my conclusions. In fact, I cannot select one of them. All these factors are important, and we should, at the level of ESGE, work on all these topics, plus the topic presented by Evelien, the topic presented by Cesare, in order to write a statement. And this statement, I think, will be helpful for you in case. I don't hope, of course, unfortunately, I don't hope we will have a new crisis, but in case we have a new crisis, any crisis, infectious, political, economical crisis. Thank you very much. So maybe we have only maybe 1 or 2 minutes to discuss. Cesare, what do you think about to write a statement?
Yeah, I feel that Thierry is very good idea. We cannot be unprepared. Of course, Thierry, this may be very provocative because in all of the 3 talks, we are also talking about big investment. For instance, if you think of alternative to colonoscopy, Evelien, we must have more machine, more manpower. The same Thierry, if we want to create new endoscopy rooms, we need to invest heavily on them. But maybe some steps are, on the other hand, very feasible. For instance, telemedicine, as you pointed out at the end, FIT, Evelien, with the new cutoff. This is also very feasible. So I guess that a position statement may help in allocating better the limited resources we do have during this crisis.
Okay. I think this crisis would help us. It is really a great opportunity to change the way we work together, and we buy device, etc. A lot of topics should be covered now, and the rules should be written, and that's why we need this statement.
I like it because I like the approach, because of course we are in a time of emergency, and we need to make sure that what we do the best way, and we do it for the patients that need it most. Okay. So I think this is the moment and the opportunity for our colleagues and ourselves to improve further and to make a big step forward. So I agree with you. I think it would be very nice to make a plea for those issues that we discussed.
Okay, because you have, okay, we have plenty of ideas. Okay, so there are a lot of topics to cover. So we should work together on this statement. So a great thank you, Evelien. A great thank you, Cesare. A great thank you to colleagues who attend this session. I hope you enjoy this session. A great thank you to ESGE and of course to IPSEN for having organized, having promoted this webinar. I wish you an excellent evening, and also, of course, and especially to my colleagues from Russia, my colleagues to Poland. I saw a lot of names from Russia and Poland on the list of attendees. So I'm very, very pleased. I'm sure that you also enjoy the meeting. Okay, have a nice evening.
Bye-bye.
Bye-bye.